today we're going to talk about vascular venous outflow obstruction, passive liver congestion, hepatic cysts, whether they are congenital or acquired, and abscess. Didn't we stop? I told y'all to stop at parasitic, right?
Abscess?
Did I told you to stop at parasitic?
Yes.
Okay. Okay, so if I have a thrombus inside of the hepatic vein or inside the IVC, it is going to affect the flow that is going back into the liver. Okay? So those are some of the things that we're going to talk about. The hepatic vein are draining into the IVC, and they should be blue. Okay? If they are not, or whether they're blocked, that's our job to be able to find that. As we are looking at the hepatic artery and the portal system and the hepatic vein, we have to make sure that it is hepatopetal flow in the portal veins, hepatopetal flow in the arteries, the hepatic artery, and then hepatofugal flow in the hepatic vein. Okay? Since the organ is such a vascular organ, then it should be a low resistance. If it was high resistance, there's something wrong with the liver. Because the liver is so vascular with the blood flow going into the liver, it should be low resistance. So we don't have a problem with flow going into the liver because it's so vascular. If it ends up being a high resistance, we've got a very sick liver. Okay? So the portal venous system is considered monophasic. It has little pulsatility. It has a flow velocity of 15 to 18 centimeters per second. It should be above the baseline because it is red and it is feeding the liver. Okay? The portal vein is flowing away from the liver. It should be hepatofugal because it is leaving the liver and going to the right to the IVC, and the IVC empties out into the right atrium. Now, if I have congestive heart failure, then my heart can't take the blood that it should, and the IVC will become dilated. Okay, and then it could back up into the hepatic vein. So because the hepatic veins are so close to the right atrial filling of the heart, with the heart beating, contraction, relaxing, the IVC can have, or the hepatic veins can have almost what looks like an arterial blood flow. They call it the W because it almost goes below the baseline, but then it doesn't. Okay, so the IVC is what we call triphasic. The triphasic is where it looks like it's sensitive to respiratory changes. Because we can have the patient hold their breath, that increases the abdominal pressure, which dilates the IVC. Okay? Portal hypertension is does affect the liver because if you have portal hypertension, the portal vein is not able to feed the liver like it should be. Just one moment. Here's self-imaging school, Miss Shepherd. Because I'm in class. Okay, bye. Just for you because I thought it was you. I love you too. No, I get out of class at 1:30. Okay, bye. Sorry, that was Miss Laura. Miss Vance is out today, so I'm in charge of the phone.
Oh, okay.
So I apologize for the interruption. So portal hypertension. There's two things that have to go along with that. Because the blood flow from the portal vein, which is the splenic vein, and the superior mesenteric vein, they join at the confluence right underneath the head of the pancreas. Okay? You can turn on it clockwise and you can see it going into the liver. If the liver is fibrotic, then we cannot feed the liver like it should. So if we can't feed the liver like it should, then it's going to back up into the spleen. If it backs up into the spleen, then we have collaterals where God finds another pathway for the liver to get its blood, or varices.
Mm-hmm.
Varices are dilated veins and arteries that take up the slack of not having the blood routed the way that it should. You have to have varices before you can get collaterals. Does everybody understand that? You're going to see varices before you see collaterals. Collaterals are just another pathway for the blood to leave an organ and enter into another organ.
Mm.
Here you see on A that you have a portal vein that is the darker orange, and then you have the hepatic artery that lays on top of that. This color image is important because what else is up there is a hepatic duct and a common bile duct. Because this is intrahepatic, if we see an anechoic structure with no blood flow, that would be the common hepatic duct. So when we measure the common bile duct, we want that to be closer to the hilum, okay?
Mm-hmm.
So it's important that you always put color in that area so that you're not measuring the hepatic artery for the common bile duct.
Yeah.
So in level B, it is showing you a low resistant hepatic artery tracing, and you can see that the image is zoomed so the radiologist can see it better, okay? Because you don't know which way the artery is going, they have it at 0. The closer to 0 for your tracing, the more accurate the Doppler signal. The closer to 60, it's going to be more inaccurate, and it should never go over 60 degrees.
Yes, ma'am.
So here we have hepatopedal flow of the portal vein in picture C. You can see by the waveform that it is phasic.
Mm-hmm.
It doesn't change much, but it is dependent upon respiration from the patient. In D, we have a middle hepatic vein, normal hepatofugal triphasic flow. The reason that it is triphasic is because it's close to the IVC, it's close to the right atrium that the IVC drains into. Another vessel that drains into the right atrium is not only the inferior vena cava, but also the superior vena cava. Both of those vessels drain into the right atrium. Bud Chiari. This is the first pathology that we're going to talk about here. It is an outflow obstruction of the hepatic vein. It could be at any level, okay? It could be, you have to find occlusion of at least 2 hepatic veins or the IVC, because it can go into the IVC from the hepatic vein. Then we can call it Bud Chiari. So Bud Chiari is obstruction of 2 hepatic veins at any level, and sometimes it will be at the junction of the IVC and the right atrium. Okay? You have abdominal pain, jaundice, ascites, hepatomegaly, and splenomegaly. Because the blood cannot leave the liver, the portal system is still feeding blood into the liver. The hepatic artery is still feeding blood into the liver. But because blood can't get out of the liver because 2 hepatic veins are completely obstructed, or the IVC is obstructed at the right atrium, it's going to cause everything to back up. Okay? So the clinical presentation is ascites, hepatomegaly, and abdominal pain. And a lot of times these are going to be non-specific, and so they're going to order an ultrasound. Okay? They're going to order an ultrasound first because it's the cheapest and the fastest. And then if we find something, then they're going to send it over to CT. If they find it in CT first, they're going to send it over to ultrasound to confirm it. So be sure to always look at your other imaging that goes along with your patients. Thrombosis of the hepatic vein. It is linked to birth control pills. Houston Community College. Hepatocellular carcinoma from a tumor evasion from hepatocellular carcinoma. Renal or adrenal carcinoma because it's traveled. Metastatic disease of the liver. Wilms tumor of pediatrics, which is a renal disease, and that is called a nephroblastoma. If it comes from the adrenal gland, it's called neuroblastoma. Don't get those confused when you're studying your pathology. Also, because of radiation to the liver, it can also obliterate the small hepatic vessels, and it can make the liver very fibrotic, so it's less pliable. So sonographic findings depend on the degree of the obstruction and the underlying cause of it. Is it caused from HCC? Is it caused from a neuroblastoma? Is it caused from a nephroblastoma? Is it because of a nephrotic liver that I can't see the hepatic vein? Is the flow reversed flow? Am I hitting them at the correct angle? Do I have hypertrophy of the caudate lobe? Because if I have hypertrophy of the caudate lobe, and that is not unusual with Bud Chiari because of the venous blood to the caudate lobe drains directly into the IVC. So with color Doppler imaging, we can see an enlarged caudate veins that are draining into the IVC. The caudate lobe is on top of the IVC, but below the left lobe of the liver. Other findings with Budd-Chiari are going to be portal hypertension. Portal hypertension is a portal vein greater than 1.3 centimeters. It has intrahepatic venous collaterals, ascites, splenomegaly, flow disturbance of the IVC, and thrombus extending into the IVC from the hepatic vein. We can do Doppler assessment of the hepatic veins and the IVC. That is part of a abdominal Doppler exam. And we look at the portal veins to determine the level of obstruction. Passive liver congestion is edema secondary to vascular congestion, and it is related to heart failure. If the heart can't take the blood coming from the IVC, which takes blood from the hepatic veins in the caudate lobe, then all of that has to pass through the right side of the heart. So if my patient has any type of cardiac or pulmonary disorders, then the secondary dilatation of the vessels will happen. If it's in the acute phase, then the liver enlarges, causing right upper quadrant discomfort. If we have passive liver congestion, the liver is easily penetrated. It's going to be edematous. You're going to have dilated vessels that are going to be able to see very well. The IVC will be dilated. The hepatic veins will be dilated. The hepatic veins will show a W-type pattern because of the tricuspid regurgitation. So the tricuspid valve is between the right atrium and the right ventricle. From the right ventricle, the blood goes through the the pulmonary artery into the lungs, and from the lungs it goes into the left atrium, from the left atrium to the left ventricle, and into the aortic valve. So when we do a Doppler tracing, we will see the portal vein is more pulsatile than a monophasic that we see normally. It could even have a reversal during diastole. So we've got to make sure that whenever we look at the liver, not only are we looking at the anatomy, but now we have to look at the vessels to make sure they're dilated, to make sure that there's no congestion of a thrombus, and if they look too large. If they look too large, you are to be measuring them closer to the IVC than not. So here you can see that the IVC is dilated. Look how large that right atrium, that right hepatic vein is. Not so much the left or the middle, and they call this the Canadian moose sign. Because the blood can't go into the right heart the way that it should, it's gonna back up into the IVC and into the hepatic veins. Passive liver congestion is they're showing a tracing of the middle hepatic vein, and you can see that it looks like a W right here. W. See it? Okay. This is a sonographic sign for us that the patient is in congestive heart failure. Okay, congestive heart failure. So in C, The portal vein is pulsatile. It should be monophasic. And you can see that the parts of the image are hepatofugal flow. So we've got to be very careful of this to make sure that we don't make a misdiagnosis. This one I didn't finish. So what term defines blood flow towards the liver?
Hepato. C.
Anybody?
C.
Hepatopetal.
C.
Hepatopetal. Okay. What vessel recanalizes in the liver with cirrhosis?
We don't see that question.
What recanalizes with cirrhosis?
Oh, the umbilical.
Collateral vessel.
Correct. The umbilical vein. It's the ligamentum teres, is the umbilical vein that is inside the falciform ligament. Okay. What is hepatofugal?
Away from the liver.
Away from the liver. Okay. Which statement is true regarding Budd-Chiari syndrome?
B. Obstruction of venous outflow. No, it's uncommon. No,
It's D.
yeah, D.
D. Requires
Obstruction of venous outflow.
hepatic vein.
Okay.
This was uncommon condition, not common. Canadian most.
Sonographic appearance associated with dilatation of the IVC and the hepatic veins due to heart failure.
A. Canadian moose.
The Canadian moose. Okay, so let's talk about hepatic cysts. Hepatic cysts are either congenital or acquired. Congenital means that you were born with them. Congenital cysts are called true hepatic cysts, and they are categorized as simple cysts related to hereditary disorders such as polycystic liver disease. You can also develop cysts from intrahepatic bile duct. Proper involution of those ductals or both, and it increases with age. Acquired cysts are trauma, parasite, or some type of an inflammatory reaction. Inflammatory. Congenital cysts are usually asymptomatic. They're usually discovered incidentally, and we're going to find them more in older patients than we do in younger patients. They're usually solitary lesions that are going to be more common than multiple cysts. The right lobe is affected as twice as often as the left lobe, and they can be tiny or they can occupy large areas. They can cause hepatomegaly, palpable nodules, abdominal discomfort. They can compress the common bile duct, causing jaundice and mild elevation of LFTs. Sonographic imaging is the choice that we want to make. Okay, let me go to the next. Okay. Congenital cysts. Did we already go through this one? Okay. Sonographically, cysts can be characterized, measured, or localized precisely for fine needle aspiration. The fluid is usually going to be straw-colored or clear. Why would it be straw-colored? Any ideas? Isn't bile kind of yellowish?
Yeah.
Okay.
Yes.
So you can also have biliomas, which are cysts that are full of bile. If you want a complicated cyst, you can also do contrast ultrasound to help differentiate the complicated cyst from a malignant process. There are two forms of polycystic liver disease. Isolated polycystic liver disease, in which cysts are only in the liver. And then you've also got autosomal dominant polycystic kidney disease, where you also have cysts in the liver, and you can also have them in the spleen, along with your polycystic kidney disease. Autosomal dominant, you have a dominant. You have a 50% chance of getting the disease because it only takes one parent. These are congenital cysts that you see on the left. It's nice, smooth borders, anechoic, posterior enhancement. A cyst is a cyst.
Mm-hmm.
Okay? The one on B is also a simple cyst. What the arrow is pointing to is a reverberation artifact, and the only way to get away from that is to move your hand on how you're hitting the organ with the ultrasound. Sometimes it can't be helped, and you would use your TGC to get rid of that. These are congenital cysts, polycystic liver disease, and C, the kidneys were normal in this patient. In D, they had recessive disorder because they also had cysts in their kidneys.
Wow.
So if I see hepatic cysts, I'm going to expect to see a kidney cyst. If they have PKD, okay, if they just have PLD, I'm not going to see a renal cyst.
Mm-hmm.
Understand?
Yep.
Okay. So this person has adult dominant PKD. You have polycystic liver disease, you have polycystic kidney disease, and you can see that the left kidney has a cyst in it also, and this right here they're pointing to is the pancreas. Okay. This is what my husband passed away from.
Wow.
PKD. His kidneys measured 29 and 27 centimeters.
Oof.
He also had liver cyst and also splenic cyst.
Oh, wow.
So, acquired cysts, they are usually going to be traumatic, such as a hematoma or a bilioma. Or they can be parasitic. If they're parasitic, econococcal. If they're inflammatory, they are called abscess. Okay? These patients are usually going to be symptomatic. We are going to see a normal cyst, where you have the 3 criteria, all the way to a complex cyst, like a hematoma. The first time we see a hematoma, it's going to be isoechoic due to fresh blood. Due to fresh blood.
Mm-hmm.
Then as the blood settles, it's going to be more hyperechoic. Then it can build septations, and then it can turn anechoic again.
Mm.
Okay? A bilioma, depending upon the age of the bile, can also either be simple or complex, because it is a cyst of bile. Hematoma. It's usually due to trauma, or it's secondary to an interventional procedure such as a liver biopsy. It could happen due to a hepatic artery aneurysm, or it could be due to pregnancy-induced hypertension. Symptomatically, the liver will be tender. If it is a significant bleed, the patient can go into shock and have low blood pressure. Your pulse rate will decrease, and your hematocrit will also drop due to blood loss.
That's what my dad had.
That's what your dad had?
Yeah, he got liver shock, and then he get into the hemorrhagic level ups. They try to.
Did he have a liver biopsy also?
I don't know, cause when I went there, they already opened up his abdomen and have the spawn inside, so they can stop the bleeding. But they did like every single day, like 5 days in consecutive, but it not really work. It stopped at some point, yeah. I guess.
Traumatic, isn't it?
Yeah.
Yeah, where they can't find the bleed, they don't know where it's coming from, and the patient just slowly passes away due to the shock on the body.
Yeah.
I'm sorry to hear that, Vicky. But
Yeah.
I'm so proud of
Now it's recall back. Like.
He would be proud. So if I have some type of a trauma, it depends on the severity of the trauma and the location of the trauma on what happens. So I could have just a bruise, which is a contusion. I can have a subcapsular hematoma where it's bled, but it's in a capsule, so it is going to stop bleeding eventually. You can have a central laceration where they can't do much about it. They can have a transcapsular laceration with rupture of the Glissen's capsule. And that is that can throw the patient into shock also. A hematoma is going to be a CT because it is usually blunt force trauma that has caused it, such as a football injury, a car wreck, and it's a very, very fast exam, and they can find out specifically where the bleed is coming from. Sonography is very operator dependent. We can see the degree of blood in the peritoneum. We can find the laceration. We can localize where it's bleeding from. But our sonographic appearance has so much to do with the age of the blood that sometimes we can misdiagnose. A datiform disease is an acquired cyst because it comes from a tapeworm. So what happens with a tapeworm, you have a cyst, but then you have daughter cysts that develop within that cyst. So they become you have the cyst, and then you have daughter cyst inside of it, and they can be varying in size and depend on the age of the larva. Will tell us where we are, whether it's just a solitary cyst with a shell-like calcification, whether you have periphery daughter cyst, whether it's honeycomb in appearance, or whether it has with or without calcification. Because if it has with calcifications, it's going to be older than what it does. So this is a patient that had a liver biopsy, and you can see in this area right here that we have a fresh hematoma because it's almost isoechoic to the liver. And then here you can see where it has actually bled, and it has turned into a hematoma that is almost anechoic with one septation. Acquired, you have an anechoic liver mass. You have enhancement that you see behind it. It appears to be like a bullseye. So they go in and they do a biopsy, and you can see that it's more anechoic on its core. It has a core around it, and then it's more anechoic to the other structures, hypoechoic, and they did an aspiration, and it ended up being a biliroma.